welcome everyone. Good to see so many people register for this webinar. I'm Nicole Lee, I'm CEO of 360 Edge. I'm also adjunct professor at the National Drug Research Institute at Curtin University. But just before I start speaking on this topic, I just want to acknowledge the traditional owners of the lands that we're working on today across the country, and pay my respects to elders past and present, and also to any Aboriginal people here on the call today. I'm personally on Bunurong land, which is also known as Melbourne. So today we're going to be talking about, I guess, options to link alcohol and drugs with mental health, some of the things that have been a little fraught in the past. And we've been working with Brisbane South PHN, and Amy from Brisbane South is here to talk about the experience working with us. And that project was really specifically targeted at linking alcohol and drugs and mental health. So it's a really good demonstration of what's possible in this space. So, you know, in terms of why we would address co-occurring disorders, I think we're all pretty well aware of the problem. It's a problem that's been around for more than 3 decades. Without really a clear workable solution. We've tried integrating systems and services and unintegrating them again, and we're still struggling to help service users to get the help that they need. We know that as many as 90% of people in alcohol and drug treatment have a co-occurring mental health disorder. Most of that would be anxiety or depression, and some of the more common high prevalence disorders. And something like 30% of people in mental health services have significant issues with alcohol and other drugs. The multiple morbidities, of course, create much more complex problems and needs. And more than that, they're very individual needs, because there's so many different combinations of different alcohol and drug problems with different mental health problems. So we're talking about solutions to multiple problems. We talk about people falling through gaps and trying to fill those gaps by previously kind of pushing 2 services together or pushing 2 systems together. And if you've ever seen me speak on this issue many times before, you will know that I don't think that type of integration is the answer to this problem. We've tried that many times, and honestly, it has never worked in any mainstream system outside the very specific dual diagnosis services. And we can't really have a whole system of dual diagnosis services because not everyone needs that kind of service. And in fact, the types of mental health problems that we see in the alcohol and drug sector are very different from the types of mental health problems that are generally addressed in the mental health sector. So we really need to think about how we can coordinate care in a different way to ensure that service users' needs are holistically met, and think beyond the systems to more to the individual and their needs. There's a range of barriers that have created this dilemma for us, including systematic factors, different models of care, different workforces in terms of training and accreditation and pay rates even, and the type of work that is done. And we don't really have a good model for how to coordinate care with for service users. So our work rests on kind of 4 key areas of 4 key areas of enablers. The first is to have really well operationalized clear models of care and to be able to understand the models of care in the different systems, and that includes primary care as well. The second is ensuring that the workforce is capable in both areas in the right way. Maintaining specialisation in alcohol and drugs for alcohol and drug services, maintaining specialisation in mental health for mental health services, but being able to holistically apply those skills in other areas for service users. We need to ensure that both systems, and we've seen this now several times highlighted recently in the Victorian Royal Commission into Mental Health, both systems are desperately underfunded. The mental health system is seriously underfunded, and the alcohol and drug system is only funded to about 1/10 of the mental health system. So is 10 times, 100 times more underfunded, if that's a possibility. So we need to really have systems that are funded well, but I guess in the absence of having all of the funding we need, we also need to think about partnerships and how we work together as well. And the fourth area that we think is really critical to success in this area is monitoring outcomes. So collecting the right data, evaluating programs, and monitoring patient outcomes as well. So that's enough for me. I will hand over to Richard or Amanda to talk about the work that we've done with Brisbane South.
All righty. Thanks, Nicole. I'm just going to set the scene for Brisbane South. So this is a really large area south of the Brisbane River. It includes metropolitan areas, rural and remote areas, island areas. That probably sound a lot nicer than maybe they actually are, but I'd like to live in an island area. Big chunk of the Queensland population, 24% of Queensland population lives in Murray PHN, about 1.2 million people, but projected to grow to 1.4 million by 2036. And this is a diverse population, a diverse catchment, high representation of people from culturally and linguistically diverse backgrounds, about 1 in 5. Lots of overlapping governance, 4 local government areas, 223 suburbs. So that's the location of the work. And maybe it'd be a good time to hear from you, Amy, about what some of the sort of drivers, some of the reasons for you to consider better coordination between AOD and mental health in Brisbane South.
Yeah, definitely. I mean, for us, one of the key things is, like you talk about, we've got such diversity, cultural diversity, but also diversity in the types of service that people get across the region. It was really important for us to really understand some of those drivers and system fragmentations from the broad breadth of of our region, basically, for those people with co-occurring mental health issues, with AOD support needs. And really what we wanted to do with this piece of work is that we wanted it to really support and drive our regional planning processes, our joint regional planning processes with Metro South, with our working together differently piece. So we really wanted to sort of get a really good understanding of where we stood, but also ensure that obviously people with lived living experience voice remains central to that. So for us, it was really important to get an understanding, but also think about what is already known about the area as well, and recognising that 360 Edge has done a lot of work within this area. So that's sort of where we started.
Thanks, Amy. Amanda, I might throw to you to talk a little bit about our approach. What did we do?
So yes, thanks, Amy, for setting the scene, and Nicole and Richard. This is the work that we undertook recently with Brisbane South PHN and in partnership with Metro South. So we undertook a literature review. We looked at some corporate docs, we looked at the regional planning documents, and we looked at published literature as well as some grey documentation. And we wanted to understand what the evidence was telling us about what works and what are the barriers to doing this work or connected care work. And Nicole's identified a number of those, which are across the literature. We were able to identify a number of key principles that should sit under connected care work. And the ones that we were able to identify included harm reduction, destigmatization, blended care or holistic care, a no wrong door approach, and being comorbidity prepared or comorbidity preparedness. So some really good principles there that sort of set the foundation for connected care work. And then we undertook an environmental scan. We looked at 5 service models that are currently operating in the Brisbane South region, some at the higher sort of regional planning level, some at the Metro South level, and some at the commissioned PHN commissioned service level. And I guess what we found was that there was some, in terms of our benchmarking work, there was some alignment with all of the key best practice, identified best practice evidence areas. And there was some alignment with the principles, but it wasn't consistent. And I think that there was some identified area of need around increasing monitoring capacity for those service models. So we then made some key recommendations, and the recommendations were really about how do you, there's lots of good information, but how do you operationalize it? How do you implement it? And so we recommended developing a regional service framework that will support implementation in the Brisbane South region. We highlighted the need for that to happen alongside workforce development. So a workforce development strategy that can be operationalised with the commission services that we did the environmental scan for, and that we wanted to think about monitoring and evaluation and enhancing the capabilities of the services to do that, beyond just reporting back to their KPIs for their funding agreements. And I think probably overall, we wanted to recommend incrementally building towards comorbidity preparedness across all of the services.
Well, I could ask a curly question from the bench here about, you mentioned something about incremental, and I think we're going to want to come back to that. But before we do, Amy, could you tell us a little bit about the impact of the work for Brisbane South and what the thinking is around next steps?
Yeah, I mean, look, I think that's interesting, the part about the incremental, because I think when we started on this process, it felt overwhelming. Like, where do you start? It's just such a big topic. And I think that actually this allowed us to think of it in that incremental sort of phase and break it down into much more manageable, realistic things that could actually have really big impacts on the community and on the people that are accessing the services. And I think that, you know, that a lot of the work that 360 Edge completed really mirrored what the people with lived experience were discussing, and really strengthened our approach, the next steps approach. And the fact that we've done this piece of work, and now we're looking at these next steps in terms of looking at that service framework and the training. And I think that again is an opportunity for us to then bring in people with lived experience about, well, what could that look like? What would that feel like? What are the things that the service providers need to consider with those things? And service providers are really keen to do this work as well, and really recognise that there needs to be some amendments to support this area.
Yeah, well, I mean, Amy, the access stigma, the access barrier stuff and stigma stuff, something that you've found out a lot about through prior co-design work. And I think that initial experience of feeling a bit disheartened by the enormity of what could be done. But I'm wondering if you could talk a little bit more about the difference between really big sweeping changes, and on the other hand, that sort of readiness for pragmatic, incremental things that can be done with the services you have engaged?
Yeah, I think for us, obviously, I mean, considering everything else that's been occurring for everybody across, but also, you know, within South Brisbane around the floods, obviously had a massive impact, and just workforce shortages and COVID and everything else that everybody's been experiencing. It feels like these incremental changes actually will be more sustainable. And, you know, when you start this journey, you think about best practice and evidence-informed models of care and, you know, all these things that, you know, that we sort of anticipated. But I think that if we can do this collaboratively with all of the key stakeholders, we'll have much better lasting change, I think, for the service system. And I think, you know, we're looking at it from this operational lens, I think, and I think there's, you know, there's other people higher up that are looking at this sort of more systems change. But I think if we can demonstrate some really good models and some really good sort of iterative changes, that then we've got bigger changes as we go along. You know, this is a journey. It's not, we've done this shiny report and that's the end of it. It's a process, and we want to continue to sort of grow in that process, I suppose.
It's like triangulating between what we know or we have pretty good evidence will work, the literature, and what's acceptable to the stakeholders, what's feasible within a particular region, and then what we can contribute to that knowledge pool by actually taking notes, actually monitoring the incremental changes that we make. Seems like a pretty reasonable way forward. So that's I guess it's Q&A time. Chris, have we got any questions in the chat from attendees?
My question was around what's an ideal experience for a person on the ground that has a comorbid condition that goes between these services, and what have you seen work well between communication and services, and yeah, what do you aspire to see as a PHN?
Oh, look, for us it's that, and this is the voice of the people that we were working with, was around having a warm and welcoming environment to come to, that even if it isn't the right place or service they're at, they felt welcomed. And I think that stigma, like Richard was talking about before, has been a massive issue and a barrier for them, feeling that they even receive that walking into services. So I think, you know, stigma underlaid everything that we spoke about within those sessions and discussed, and that's something that's going to be an ongoing piece of work that we will sort of work on at Brisbane South.
I think what you talk about there and what we subscribe to as well is truly client-centered care. So it doesn't really matter what that person comes to you with. There is no kind of best practice for that individual person necessarily, but we need to ensure that we understand everything that they're bringing that impacts on their mental wellness, including the alcohol and drugs and mental health issue, and addressing all of those in some...
Finish Nicole's sentence, in some meaningful way. And that, just to add to what you said before, Amy, we shouldn't expect people to be experts in the service system that they're desperately trying to get into, or service systems that they're desperately trying to get into. So that kind of no wrong door principle that a few of you have mentioned, that we should be anticipating and trying to get access barriers out of the way. And a big part of that would be how we communicate or add to stigma around treatment access as well. That maybe just to be the cynical stick in the mud with the point Nicole was making, that we do want individualised care, but that's happening within the boundaries of what we know works. So there needs to be a kind of an evidence base that supports any treatment or support intervention, but that the sign on the door doesn't preclude us being able to screen for or help someone recognise, explore readiness and motivation to address a much wider range of issues than perhaps what the sign on the door would suggest we can do. And that again, I think raises some concerns for people about how competent do we need to be in everything that someone could potentially ask for help with, And that, I think, comes back to some of those discussions you raised before, Amy, about partnerships and coordination between services. So we don't need to know how to do everything, but we certainly need to know how to point people in the right direction.
And I think that's the comorbidity readiness. Is like it has to be not a one size fits all, but what does that mean for your service, and what are your capabilities in terms of your processes, your clinical capacity, your workforce skills, and your assessment processes. But in the background, it's all about collaboration and referral in terms of when you meet those thresholds, you actually have those relationships and referrals and partnerships in place to kind of work with your service partners to meet the needs of that consumer.
Mm. And look, I guess the other part of this is we want to design these services in a way which allows stakeholders, including service users, to have an input. So the next steps for us essentially are looking at elements of the service system that are feasible and amenable to change to improve connected care outcomes. So in the nicest possible way, I think this is probably a callback for everyone here to keep your eyes peeled, because we will come back to you with the service model that's been designed collaboratively for Brisbane South, and we should have some insights about impacts on connected care outcomes, and also some more information about what this means in terms of workforce. What do we actually need to help people feel comfortable and competent in? And also some information about the burden associated with monitoring and evaluation as well, and hopefully we can demystify that. But I imagine in 12 to 18 months we'll be doing another one of these and talking about the results, which we're really excited about. So I'm conscious of time, folks, and I'm conscious that, as far as I know, my audio is working, so I probably will just take responsibility for wrapping this up, folks. Thanks for coming. It's been a fantastic turnout, probably one of the biggest. Apologies that the Q&A didn't work. There should be some opportunities to get in contact with us through the invitation. If you'd like to engage with us following the workshop, we'd love to hear from you, and perhaps we can jump into some specific questions there. But otherwise, a big thanks for coming along. Amy, tremendous thanks for coming in, sharing the opportunity to talk about the work today, but also engaging us in the first place. And everyone, will see you in the next webinar. Thanks heaps.
Thank you. Bye-bye.